Okay, can everyone hear my voice now? Yes or no? Okay. So my apologies now. So we were on the process of talking about cardiac tamponade, and Dr. Hagar was explaining or what cardiac tamponade is. So Dr. Hagar, one more time, if you wouldn't mind, what is cardiac tamponade, please?
Yeah, I said any kind of fluid surrounding the heart and prevent it from making the normal
Very,
contraction,
very good.
either blood or fusion or anything from outside.
Very good. Okay, so if if this type of patient comes to your clinic or your ER, are you going to see Beck's triad, hypotension, jugular venous distension, and muffled heart sound? Yes or no?
Yes, of course.
Yes. Okay, that's that. And if you do an EKG, guys, what are you going to see on an EKG? Can I get some fast answers, please? On an EKG, we will see electrical alterance. Very good, Dr. Hagar. Thank you so much. And what sort of pulse can we see over here? The name of that pulse is?
Pulsus paradoxus.
Very good. Thank you so much. So that is pulsus paradoxus. Okay. So that's that. So over here, let's use our red pen to identify what the questions are. Okay. The questions are over here from cardiac tamponade. You can see electrical alterance that'll look like this, either up or down, up or down. So it's alternating. Then what is cardiac tamponade? This is compression of the heart by fluid. As a result, we will get obstructive shock-like findings. The patients will come to you with complaints of sudden onset of shortness of breath, chest pain can be there, and with their patients will have a history of trauma, right? Patients will have a history of trauma, majority of the patients. Or patients can have history of radiation or chemotherapy, okay? So that these are another source of condition where we can have accumulation of fluid. Next one is patients will have Beck's triad, that is hypotension, distended veins, and distant heart sound. This is very high yield. Patients will have pulsus paradoxus, that's very high yield. Okay. And treatment is either pericardiocentesis or surgical drainage, very high yield. And then what is pulsus paradoxus? Decrease in amplitude of more than 10 millimeters during inspiration. And where do we see them? We see them in these 5 conditions: constrictive pericarditis, obstructive diseases such as croup, obstructive sleep apnea, asthma, COPD, and cardiac tamponade. Are we clear, yes or no? Everyone? Okay, so let's begin with the next topic, that is bacterial endocarditis. What is bacterial endocarditis? Bacterial endocarditis is basically when the heart valves, right? The heart valves, the mitral valve, the tricuspid valve, and over here we have the pulmonary valve or the aortic valve. Mostly in mitral valve, we have the most amount of endocardial vegetation. The reason being is because the amount of pressure over here is very high. So what does this mean? Let me tell you very quickly. Is in the heart, right? Over here in the heart, the amount of blood that's coming from the left atrium and that's going to the left ventricle, is it very high or is it very low? The answer is it's very high, right? So the amount of wear and tear that we will have, will it be higher in the mitral valve? Yes or no? The answer is yes. So if there is a high amount of wear and tear and endothelial injury, isn't it easier for organisms to come and deposit over here in the mitral valves? Yes or no? The answer is yes. Okay, so that's that. But when will we have tricuspid valve involvement? Tricuspid valve involvement will basically happen when, if, for example, let's say that there's a patient who is an IV drug abuser, right? If there's a patient who is an IV drug abuser and with a needle, they are injecting heroin, morphine, or whatever, and when they break their skin, the skin has the normal flora, that is Staph aureus, that stays in a small amount, and that Staph aureus can enter the blood vessel after the puncture of the skin by the needles. And obviously all the blood from the body goes to the right atrium, and it goes to the lungs. Before it does that, it has to go through the tricuspid valve. So in these cases, there could be tricuspid valvular endocarditis. Have I made myself clear? Yes or no? That's that. And that's another one. Another one is, give me 1 second. Okay. Another one is, can you guys hear my voice? Yes or no? Can you guys hear my voice? Is the voice clear? Okay, good. Another one is basically if there's a valve that is already injured, right? If there's a valve that is already injured, and on an injured valve, if we have deposition of bacterial organisms, right? Then this type of valvular endocarditis is called subacute endocarditis. Okay, subacute endocarditis. If there was a valve that was previously normal, and now all of a sudden there is vegetation. So previously the valve was normal, now the valve has sudden vegetation. We call this acute endocarditis. If previously the heart valve was damaged, and on a damaged valve, if we had depositions of bacterium, then these will be called subacute endocarditis. Are we clear, everyone? Yes or no? Okay, now the problem is what? The problem is that when blood goes from the left atrium to the left ventricle and to the systemic circulation, isn't there a possibility they will carry these thrombotic bacterial emboli with them? Yes or no? The answer is yes, they will carry the emboli with them. And these emboli, where will they basically deposit? The answer is they can deposit absolutely anywhere in the body, right? Absolutely anywhere in the body they can deposit. So if this is your patient, the emboli, can they go to the brain and deposit and cause stroke? Yes or no? The answer is yes. In the eyes, can they deposit and cause retinal hemorrhage? The answer is yes, right? Then what else? Over here, we have the lungs. Can they go to the lungs and cause pulmonary embolism? The answer is yes. Can they go to the kidney and form microthrombotic emboli? Yes or no? And decrease glomerular filtration rate and cause AKI? The answer is yes. Can they deposit in the nails? The answer is yes, as splinter hemorrhage. Can they deposit in the hands and palms of the soles as these? The answer is yes, right? If over here, if it's painful, then we call them, if it's painful, then we call them ostlers. How? Because pain, whenever we feel pain, what do we say? We say ouch, right? So ouch, O for ouch, O for osler. If it's painless deposition in palms and soles, painless depositions, then we call them Janeway lesions. Janeway lesions. Are we clear? Yes or no? So that's basically what it is. Patients, can they also have, since there is bacterial development, can we also get fever? Yes or no? Can we also get fever? The answer is yes. Okay, so that's that. Now, what are the most common type of organisms that will basically cause bacterial and endocarditis? Okay, now the most common type of organisms that will cause bacterial endocarditis is, first of all, in acute bacterial endocarditis. Can anyone tell me what do we mean by acute? Can I ask this to Dr. Dalia Ahmed? What do you mean by acute endocarditis?
Acute endocarditis is inflammation in the endocardial muscle of the heart.
Yes, but why do we call this acute and not subacute? What is acute endocarditis? Is it because the heart valve was previously normal and now all of a sudden we have a accumulation of organism in the heart valve? Is this why?
Yeah,
Yes or no?
right.
Yes,
Yes.
very good.
Yeah.
Thank you so much. So that's basically the reason. So what is an organism that can damage the heart valve that was previously normal? So if we think about the organism, first of all, these types of organisms, should they be highly virulent and dangerous? The answer is yes. So the number one organism is Staph aureus, and we know how virulent Staph aureus is. Next one is subacute. Subacute is basically, For example, if there's a patient who has hypertension, right? If the patient has hypertension, in hypertension, do the valves face a lot of endothelial injury and wear and tear? Yes or no? The answer is the valves, they have a lot of endothelial injuries and wear and tear. So are they healthy valves or unhealthy valves? The answer is that they are unhealthy valves. In these patients, if they ever undergo a dental procedure, right? We know that in our mouth, we have a high yield flora that is Viridans group of streptococci, where we have Streptococcus mutus, Streptococcus mitens, right? Mutus and mitens, right? We call them Viridans group of streptococci. They have a tendency of accumulating in the mouth because they can form biofilms. So if there is a patient who has a previously unhealthy valve and they undergo a dental procedure, can these organisms move from the oral cavity and through the saliva? Is it possible for them to get disseminated and enter the systemic circulation and come and accumulate over here? The answer is yes. Okay, so that's that. Another one is, let's say that there's a patient who has colon cancer. If they have colon cancer, then these patients, they have a high amount of colonic organisms such as Streptococcus bovis, right? Streptococcus bovis, these organisms, they have a tendency of getting released in the body and accumulating in the heart valves, resulting in another type of endocarditis. So if we see Streptococcus bovis in our endocarditis, can we do colonoscopy to make sure that the patient does not have colon cancer? Yes or no? The answer is yes. Another type of patients are patients who have prosthetic implants or catheters, right? In these patients, I talked about this at the beginning of the lecture. What type of organisms will form vegetations in the valves? The answer is Streptococcus Staph epidermidis. Okay, Staph epidermidis. Now, next one is over here. If there is a patient who comes to you with endocarditis, are you going to do a blood culture? Yes or no? Right? Yeah, you're going to go. So the thing is, if you do a blood culture, and if the blood culture of the patient, hear this question, this is extremely important for you, step one, this is a difficult question. If a patient comes to you with endocarditis, and we do a blood culture, and if the blood culture comes back negative, but the patient has strong sign symptoms and imaging finding that is positive for endocarditis, what are the two organisms you will think about that is the reason for the endocarditis? Does anyone know? Did you guys understand my question? If there's a patient who has strong sign symptoms of endocarditis and imaging that indicates endocarditis, but in blood culture it's negative. Yes, very good. The two organisms that we will think about that is causing the endocarditis but will not show up in culture are, number one, Coxiella burnetii, and Bartonella hensleyi. Bartonella. Okay. Are we clear, everyone? Yes or no? Okay, good. Another one is, let's say that we see that over here, there are another group of organisms that we call as HACEK group, HACEK. HACEK group of organisms are basically organisms that will accumulate in the endocarditis. You know, like how some organisms, they have a tendency of accumulating in different parts of the body, yes or no? Just as how that's the case, we have HACEK organisms that have a tendency of accumulating in the valvular endocardium. This HACEK group of organisms stands for H for Haemophilus, A for Acinetobacter, or nowadays we call this Aggregatobacter, C for, we call this Cardiobactum, E for Eikenella, and K for Kingella. Okay, are we clear? So you do not have to remember the names of these organisms, but if there is a patient who has sign symptoms of endocarditis staph negative, epidermidis negative, volvus negative, blood culture is positive, right? But we do not know the organism. If blood culture is positive, then, and if all of those organisms are negative, then we can think about these 5 organisms: Haemophilus, Acinetobacter, Cardiobacter, Eikenella, and Kingella. Are we clear, guys? Yes or no? Okay, so let's begin. Over here, Dr. Jorge Otero, you will see is over here. Okay. Oh, what I said was, if the blood culture is positive, but endocardial, let's say you take a small tissue of the endocardium from the valve, and over here and over there you cannot grow the organism, but your blood culture is positive, then you have to think about these 5 organisms, Tay-Sachs group of organisms. Okay. Next one. Let's underline the organisms: acute Staph aureus, subacute virulent streptococci. We talked about this. This is due to a sequelae of dental procedure. The onset is gradual. This is a rapid onset. Symptoms of bacterial endocarditis are fever, rot spot, Osler's node, Janeway lesion, splinter hemorrhage, and nail bed. And basically everywhere where the emboli will go, microemboli. Write down over here, microemboli can go anywhere. If they go to the brain, they will cause stroke. If they go to the renal system, they will cause AKI. So that it's associated with glomerulonephritis and septic pulmonary emboli, exactly what I just said over here. This may be non-bacterial in some cases, meaning the bacterial endocarditis can be not due to a bacteria. It can be due to malignancy, where instead of bacteria, we have depositions of tumors, hypercoagulable state, where we have depositions of cholesterol, or lupus, where we have depositions of antigen antibody complexes. So that's that. That is not important for now. We'll talk about this later. For now, remember the names of the organisms and the conditions in which they accumulate. The sign symptoms are over here with from Jane as a sort of mnemonic. It requires multiple blood cultures. If the blood cultures are negative, then we think about Coxiella burnetii and Bartonella. This is exceptionally high yield. Mitral valve is the most frequently involved. This is extremely high yield, this line, because they ask you this. Tricuspid valve is associated with IV drug abuse. This is very high yield. That's that. It's associated with staph, Pseudomonas, and Candida. That is the IV drug abuse one. Okay, if it's not staph, then it could be Pseudomonas or Candida. Streptococcus bovis is present with colon cancer. That's very high yield. Streptococcus epidermidis is with prosthetic valve. That's very high yield. Another one, write down: Vibrio, para, hemolyticus. If it grows in the organism, in the valve, then this is because the patients have an underlying hemochromatosis. Okay, are we clear? Yeah, everyone? So we have Staph aureus for acute, Staph epidermidis for prosthetic, virulence for subacute, Streptococcus bovis for colon cancer, and Vibrio parahemolyticus for hemochromatosis. Okay. And some organisms that are positive for blood cultures, but they cannot grow, are the HASEC organism, that is Haemophilus, Acinetobacter, or we call this Aggregatibacter nowadays. Before we used to call this, Actinobacillus or Acinetobacter, the same thing. Cardiobacter, Eikenella, or Kingella. Okay. Are we clear? Can we move on to rheumatic fever? Yes or no? Okay. Are you guys understanding the lecture? Yes. Okay, good. Now, what is rheumatic fever? Can anyone tell me what rheumatic fever is? Rheumatic fever is basically, first and foremost, we have disease, right? We have an upper respiratory tract infection or a sore throat with an organism that is a group A beta hemolytic streptococci, right? And then what happens? What happens is when we have a group A beta hemolytic streptococci, there is formation of there's formations of antibodies, right? There's formations of antibodies against these organisms. And the antibodies that are formed against group A beta hemolytic streptococci, they have a tendency of attacking other tissues. This phenomenon, do we call this phenomenon as cross-reactive antibodies? Yes. So basically, what does this mean? You know, like how, okay, let me tell you. Over here, let's say that this is a city, okay? This is a city. In this city, we have a new group of criminals, okay? And to fight this new group of criminals, we have new policemen, new red policemen. Now, if the policemen, along with killing the criminals, if they also kill the normal population or the normal humans in the city who are not criminals, can we say that these new policemen they are cross-reacting? Yes or no? That is, they're killing the criminal and they're killing the normal civilians at the same time. So the same way in our body, whenever we have an antigen and we have the formation of antibodies that can destroy or damage our own tissue antigens, we call this phenomenon as cross-reactivity. Okay, so that's that. So what happens is it's a consequence of infection where we have formation of antibodies against the group A beta hemolytic streptococci. And these antibodies, what they do is that they have a tendency of forming, they have a tendency of forming some pathological bodies called Ashkoff bodies. What are Ashkoff bodies? Ashkoff bodies are basically, they are granulomas. Okay, they are granulomas. And whenever we have granulomas, do we have macrophages? Yes or no? Epithelioid cells? The answer is yes. The name of the macrophage over here in Ashkoff bodies, due to the formation of antibodies in the body, is called anisco cells. Anisco cells. Are we clear? They're called anisco cells. That's that. And over here in rheumatic fever, there is a possibility that we can have these antibodies that can attack two regions. One are the valves, another one is your glomerulus. Yes or no? So can they cause, after infection, can we get a mitral valve formation of anisco bodies and Ashkoff bodies in the mitral valves? Yes or no? Okay. So what sort of disease shall we have? If we have a rheumatic fever in the mitral valve, because that valve is the most highly affected valve because of the high pressure it goes through, then in early phases, we will have, yes, endocarditis will be there, okay, but in early phases, we will have valvular problems. We will have mitral, what, in early phases, what will we have? Mitral stenosis or mitral regurgitation? Mitral regurgitation, right? And later, okay, for example, if this is the valve, right? In early stages, we will have antigens forming Ashkoff bodies over here, and the valves will get weak and they will regurgitate upwards, right? Over time, when the antibodies they are present over here, they will over time block the pathway of the blood, and patients when later they will get mitral stenosis. Okay, so early is always mitral regurgitation, and late manifestation is mitral stenosis. Are we clear? Yes or no? Everyone? Okay, so that's that. Now, if a patient comes to you with signs, symptoms of valvular abnormality, with a history of group A beta hemolytic streptococcus antigen, what are we going to suspect? We're going to suspect rheumatic fever. Another thing is, if we see mitral stenosis in a young patient of 30, 35, 36 years, can we instantaneously think of rheumatic fever, please? Yes or no? The answer is yes. Okay. What are some of the other things that we will find in rheumatic fever? We have some criteria, yes or no? We have some major criteria and we have some minor criteria. What are the major criteria? The major criteria are Jones criteria. What do we call as Jones criteria? These are, for example, number one, J for joint pain. or we call this migratory polyarthritis. Polyarthritis, and migratory means that they will migrate, right? What does this mean? Migratory, that the pain will migrate from the hands to the feet, from the feet to the hands, then from this hand to this feet. This will be asymmetric and uncoordinated joint pain. So that's why we call this migratory. Next one is that we will find O. O is for the fact that O looks like O can be heart shaped. So O is for heart problems. We have endocarditis, myocarditis, and pericarditis. So all of this, as a whole, we call this pancarditis. Okay, so all the layers of the heart will be inflamed. Next one is, can we find subcutaneous nodules in the skin in rheumatic fever? The answer is yes, because antigens, they cross-react with the skin tissues. Then what else? Can we find erythema marginatum if the antigens cross-react with blood vessels? The answer is yes. So erythema marginatum. And if the antigens cross-react with the tissues of the central nervous system, then can we get a Sydenham chorea? Sydenham's chorea, yes or no? The answer is yes. Can anyone tell me the minor criteria? Minor criteria are fever, ESR, and CRP. Okay. Are we clear, yes or no? Okay, good. So over here in rheumatic fever, what sort of a hypersensitivity reaction is this? Type 2 or type 3, where we have formation of antibodies directly against the antigen? The answer is this is a type 2 hypersensitivity. Okay. Very quickly, what are the types of hypersensitivity? Can anyone tell me? What are the 4 types of hypersensitivity? Number 1 is type 1, where we have mast cell deactivation, right? Number 2, type 2, is where we have antibody formation against antigens in the body. Type 3 is where we have antigen antibody complex that deposits in different portions of the body and initiates inflammation. Type 4 is direct T cell mediated, direct cytotoxic CD8 T cell mediated damage. Okay, so over here, rheumatic fever is which type of a hypersensitivity? 1, 2, 3, or 4? The answer is this is a type 2 hypersensitivity. Okay, that's that. Treatment is very simple. Treatment is with penicillin. Are we clear, guys? Yes or no? Yes. Okay. Do you guys remember that at one point I talked about how cardiosyphilis can cause endarteritis, inflammation of the vasa vasorum, and as a result, if this is the ascending aorta, if this is the vasa vasorum that's supplying the ascending aorta, and if there's inflammation of this end arteries, can the vessel get weak? Yes or no? The answer is yes. Can the valves get weak? Yes or no? The answer is yes. Is there a possibility that in these patients there could be aortic regurgitation, aortic valvular regurgitation? The answer is yes. Okay. Also, due to the weakness of the blood vessel, can there be aneurysms? Yes or no? The answer is yes. Can there be dissections? Yes or no? Yes. The answer is yes. Can there be rupture of the aortic valve or the aortic ascending aorta? The answer is yes. Okay, so that's basically what it is. So these are all the findings of syphilitic heart disease. Syphilitic heart disease, there would be disruption of the vasa vasorum, resulting in continuous inflammation, will result in long-term calcification, which leads to a tree bark appearance of the aorta. Do you want to see the tree bark appearance of aorta, how it looks like? Tree bark aorta. Okay. This is how the aorta would look like. Doesn't it look like a bark of a tree? Yes or no? Yes. Do you see how dilated the vessels are? What is this dilatation called in this blood vessel over here? This dilatation. What is this? this dilatation in the blood vessel? Isn't this an aneurysm? Yes or no? Yes or no? Doesn't this look like an aneurysm? Yes. Okay, so that's that. Are we clear? Yes or no? Now, let's move down to acute pericarditis, myocarditis, and cardiac tumors. And then after that, we will be done. Before talking about these conditions, do you guys want to take a small 5-minute break? Yes. No. So let's take a small 5-minute break. After that, let's come back and finish the last 2 pages and ECG tracings. And then after that, we will finish cardiac pathology. Okay, thank you so much. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Okay, so let's begin our lecture. Is everyone ready? Okay. What is the name of the layer layer that encircles the heart? Do we call that pericardium? Yes or no? The answer is yes, right? Isn't there a possibility that we can get inflammation of the pericardium due to multiple reasons, right? We can get inflammations of the pericardium due to multiple reasons. Number one is the number one most common cause of having inflammation of the pericardium. The most common cause is an underlying viral infection. Yes or no? For example, nowadays, are you guys aware that coronavirus can affect the layers of the heart? Patients have died due to myocarditis, pericarditis, and all of those things. The answer is yes. So viral infection is very high yield, and it's one of the most important cause of pericarditis. Next one is one of, if you have to talk about most common, then can we say post myocardial infarction? Yes or no? If it's 1 to 3 days, then fibrinous. If it's more than 2 weeks, we call this Dressler syndrome. Yes, one is due to neutrophil, another one is due to autoimmune activity. Okay, next one. If there's a patient who has been radiated in the chest, is there a possibility they can have pericarditis? The answer is yes, right? So radiation. Then what else? If the patients have another high yield for USMLE step 1 is this. A patient of AKI, acute kidney injury, is the urea level high in these patients? Yes or no? The answer is yes. Urea has a tendency of causing inflammation of the pericardium. So patients, they get uremic pericarditis. Uremic pericarditis. This is exceptionally important for step 1 because in step 1, this type of question allows the physicians or the people who makes the question, this allows them to tie two organ systems together. That is the kidney and the heart. So with one question, they can understand your knowledge about the renal system and the CVS system. So next time, if you see a patient in your question stamp who has acute kidney injury, creatinine is very high, the patient is not undergoing dialysis, all of a sudden the patient has a sudden onset of sharp, severe chest pain, what are we going to think about? We are going to think about uremic pericarditis. Are we clear? Yes or no? Okay. Are we clear about this, guys? Can I get a quick yes or a quick no, please? Okay, good. Clear. Next one is, another one is, can we have pericarditis with an underlying disorder or a chronic infection such as SLE? What is SLE? Does anyone know what SLE is? Please write yes or no. If you do not know what SLE is, please write no. Yes, okay. We have 3 physicians who knows what SLE is. Okay, so don't worry, I'm not going to ask you a question what SLE is. I'm not going to ask you to unmute yourself and tell me the answer. Let me just tell you what SLE is. SLE is basically a disease where we have formation of antibody against DNA complexes. So isn't there a possibility that there could be formation of antibody against every tissue in the body? Yes or no? Yes? Okay. So even the one in pericardium, there could be formation of antibody against the pericardium and patients can get affected. Can we have pericarditis in rheumatoid arthritis? Yes or no? In rheumatoid arthritis, the answer is yes, because in rheumatoid arthritis, is this a chronic infection? Yes or no? The answer is yes. It's an HLA associated disease where patients have insidious onset of polyarthalgia, that is joint pain. In these types of chronic infections, we have a high amount of cytokines and clinical and inflammatory mediators. They can go to the pericardium and they can cause inflammation of the pericardium. Okay, are we clear? Yes or no? So treatment-wise, treatment for acute pericarditis is very important. Oh, before we talk about treatment, let's talk about the finding. In EKG, if a patient comes to you with a history of viral infection, history of post-MI, or a history of acute kidney injury, right, or with a history of SLE and rheumatoid arthritis, now they come to you with a sudden onset of sharp, severe chest pain. And you do an EKG, what are you going to find? Right? First of all, what is your diagnosis for this patient? Your diagnosis for this patient is acute pericarditis. Will there be a friction rub on physical examination? The answer is yes. Will the patient lean forward to decrease the pain? The answer is yes. Okay. Will the patient have severe chest pain? The answer is yes. Next one, what are the findings that we will see on an EKG? On an EKG, we will find two things. Number one, since there's inflammation of all the layers, we will have ST elevation. And there's another thing, we will have PR depression. ST elevation and PR depression. What was the EKG finding for cardiac tamponade? Fast answers, please. What was the EKG finding for cardiac tamponade? Electrical alterance. Very good. Thank you so much. And what is the EKG finding for your acute pericarditis? ST elevation and PR depression. Are we clear? Yes or no? Okay. In these patients, how are you going to treat them? First of all, in these patients, how are you going to treat them? Do you remember how I just said that in certain diseases such as SLE and rheumatoid arthritis, we have a lot of chemical mediators and cytokines that are resulting in inflammation? The answer is yes. So to decrease the cytokines and prostaglandins and the mediators, what is the drug of choice? NSAIDs. Will they decrease the pain? The answer is yes. The first choice is NSAID. But if someone has peptic ulcer or bronchial asthma, are you going to give them NSAIDs? The answer is no. In those patients, what drug will you choose? You will choose a drug called colchicine. 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 What is the mechanism of action of colchicine? Colchicine is a drug that will prevent neutrophilic diapedesis, meaning neutrophilic movement. If it decreases neutrophilic movement, then can neutrophil go to the pericardium and cause inflammation? The answer is no. As a result, will the inflammation decrease? The answer is yes. Okay, are we clear? Yes or no? Okay, so that's that. Next one is if NSAID and colchicine does not work, are you going to give steroids to decrease overall inflammation? Yes or no? Corticosteroids, the answer is yes. But before prescribing steroids, do we have to make sure the patient has no infection? Yes or no? The answer is yes. Okay, are we clear? Now, let's talk about another one. Let's talk about myocarditis. Myocarditis is inflammation of the myocardium. Oh, okay. Let me just underline the information. Over here, everything is important. There's nothing to underline. Everything is important. Everything. Questions are going to come from the sign symptoms. The answers they're looking for are your knowledge, whether you know the treatment, whether your knowledge about the cause from over here. Uremia, where is uremia? Uremia is very important. Radiation is important. And viral is important. Okay. So that's that. What is myocarditis? Myocarditis is inflammation of the myocardium, where we have global enlargement of the heart and dilatation of all four chambers. Why? Due to inflammation. We have exudation, right? We have exudation and edema, localized edema, and all of those things. They will cause global enlargement of the heart. Presentation can differ, but patients will have chest pain, dyspnea, and arrhythmias, and that's the thing. Now, over here, there's another thing that patients will also complain of palpitation or tachycardia. And we usually know, for example, if a patient comes with tachycardia and fever, can we assume that the tachycardia is due to the fever? Yes or no? The answer is yes, right? The tachycardia is due to the fever. But if the tachycardia is way more than the fever, then is that abnormal? The answer is yes, right? So over here in myocarditis, this is one very typical finding, that the tachycardia will be beyond the proportion of fever. Okay, so excessive tachycardia. So that's that. Once again, do you remember yesterday our discussion that whenever the heart muscles are involved in some sort of an inflammation, the SA node, AV node, they start freaking out and they conduct a lot of electrical impulses? Yes, do you remember that? Exactly. So that's why they will get arrhythmias and tachycardias. What are the common causes of myocarditis? Number one is viral. Once again, viral disease, adenovirus, Coxsackie, parvo, and HHV. What do we find if it's a viral infection, neutrophil or lymphocytes? The answer is we will find lymphocytic infiltrate with biopsy. So that's that. This is exceptionally high yield. Then we can later have parasitic inflammation, bacterial inflammation, toxins, rheumatic fever, drugs, and autoimmune, where we have a disease called Kawasaki's disease, which is a sort of vasculitis. Over here, who is the student who remembers Kawasaki's disease? Kawasaki's disease. It's a medium vessel vasculitis that is more common in Asians. Yes or no? Fast answers, please. And young children. The answer is yes. What are the sign symptoms? The sign symptoms are conjunctival injection, rash, adenopathy, strawberry tongue, and hand and foot rashes, hand and foot rash. Okay, very good. We'll talk about this in details in the future. In rheumatology, I'll talk about this. Okay, I'll talk about this in rheumatology. So that's that. Next one is sarcoidosis, SLE, polymyositis, and dermatomyositis can also cause myocarditis. Are we clear? Now, what is the cause of death of myocarditis? Can we get sudden cardiac arrest? Yes or no? The answer is yes. Are you guys aware that that coronavirus has also caused a lot of death due to myocarditis? The answer is yes or no? The answer is yes. Patients, when they were affected with coronavirus, the virus causes inflammation of the myocardium. As a result, there was severe arrhythmia due to the fact that the SA node was freaking out. And as a result, patients had sudden cardiac arrest and death. Okay, are we clear? Okay, good. Now, let's come to over here. Let's talk about cardiac tumors. What is cardiac tumor? Cardiac tumor is a very uncommon phenomenon where we have tumors in the heart. Now, either it could be primary or it could be secondary. If it's a primary tumor, it's mostly benign, right? It's a mostly benign tumor. And that tumor has more tendency of being in the left atrium. Do you remember we did a question about this in the MBOS, yes or no? That there was a sound. Do you guys remember the sound? A sound of plop, plopping, the sound. Yes, there was a plopping sound. Was it a systolic sound or a diastolic sound? It was a diastolic sound because during diastole, the blood moves from the left atrium to the left ventricle and they have to go through the tumor. As a result, they make a plopping sound during early diastole. This is very characteristic of a cardiac myxoma, okay? Very characteristic of a cardiac myxoma. In a patient of cardiac myxoma, can we also see Ortner syndrome? Yes or no? Dysphagia, hoarseness? Yes, the answer is yes. Why? Because the esophagus is behind the left atrium. Okay, so that's why. Myxomas are the most common primary tumors in adults. They can have a ball valve obstruction of the left atrium with multiple syncopal episodes because blood cannot go properly. The thing is, interleukin-6 is produced by myxomas, which can cause fever and weight loss. Do you guys remember interleukin-6 is a cytokine that releases a lot of APRs, acute phase reactants. It stimulates a lot of acute phase reactants such as ESR, CRP, fibrinogen, yes, and all of the different types of acute phase reactants. Who remembers this from immunology? Does anyone remember this from immunology? Yes, okay, so that's that. So this tumor has a tendency of producing a lot of interleukin-6. So can we have exacerbation of acute phase reactants? Yes or no? The answer is yes. Can patients have increased fever and inflammation? The answer is yes. Okay. Now, cardiac myxomas are a connective tissue tumor that we usually find in the left atrium in adults. In children, we find rhabdomyomas, which are skeletal muscle tumors, right? These are primary cardiac tumors in children. And unlike myxomas, rhabdomyomas in children are more common in the ventricles. For this, I'm going to use a blue mark because it's not very high yield. They do not really question this, but this has a potential of being asked in the future. Okay, so blue. Next one is Kussmaul sign. Does anyone know what Kussmaul sign is? Kussmaul sign? Yes or no? Okay. Okay. When we have increased during inspiration, during a normal inspiration, do we have increased venous return or decreased venous return? In normal inspiration, do we have increased venous return or decreased venous return? Fast answers, please. We do not have all day. We have increased venous return, right? If there is obstruction of the right atrium to the right ventricle pathway by any reason, so during inspiration, and if we have increased venous return and there is an obstruction from the pathway of right atrium, right ventricle, can there be dilatation of the jugular vein? Yes or no? Can there be dilatation of the jugular vein? The answer is yes. So what is Kussmaul sign? Kussmaul sign is dilatation of the jugular vein on inspiration because of impaired right ventricular filling. That's that. Okay. So paradoxical increase in jugular venous pressure. I'm going to use my red for this because it's important. Due to the negative interthoracic pressure created by inspiration, resulting in increased venous return. And as a result, this increased venous return will cause jugular venous distension. In a normal human, the jugular venous pressure should fall, but if there's an obstruction in a patient, then the jugular venous pressure will increase. What is the pathology? Pathology is that there's an impairment of right ventricular filling. As a result, blood backs into the vena cava, venous return is decreased, and patients get Kussmaul sign. This may be seen with what sort of conditions? Constrictive pericarditis, restrictive cardiomyopathy, cardiac tamponade, right heart failure, massive embolism, and ventricular tumors. The causes are very important. Okay. Let me tell you how you remember the causes of Kussmaul sign. Okay. Are you guys ready? Yes or no? Are you guys ready? Okay. So how do we see the causes of Kussmaul sign? First and foremost, what is the main pathology of Kussmaul sign? The main pathology of Kussmaul sign is that the right ventricle cannot push the blood out to the what? To the lungs. Yes? Okay. So number one, if there's an embolism in the lungs, if there's an emboli in the lungs, can the right ventricle push the blood out? Yes or no? The answer is no. If there is fluid around the heart, can the right ventricle push the blood out? The answer is no. So cardiac tamponade. If there is a layer of fibrosis around the heart, can the heart push the blood out? No. The answer is constrictive pericarditis. If there is restriction of the movement of the heart due to depositions of amyloid, sarcoidosis, hemochromatosis, endocardial fibroelastosis, then can the heart push the blood out? The answer is no. So restrictive cardiomyopathy. Yes, are you guys understanding? Yes or no? Okay. Another one is if there is a tumor, then once again, there's an obstruction and the heart cannot push the blood out from the right to the left. So tumors. These are the 5 causes of Kussmaul sign. Are we clear, guys? Yes or no? Yes. Okay, good. Next one. Next one is you have a patient who comes to you with recurrent history of epistaxis. What are your differential diagnosis? Recurrent epistaxis. If a patient comes to you with recurrent epistaxis, what are we going to think about? First and foremost, we can think about clotting or bleeding problems. Yes or no? Clotting and bleeding problems. Okay. Can we think about bad habits such as what? Nose picking? Yes. Okay. Next, can we think about using vasoconstrictors all the time for decongestant? For example, nasal decongestants. Yes or no? they weaken the blood vessels of the nose, nasal decongestants, right? Then can we think about cocaine abuse? Yes or no? Because cocaine is taken by the nose, right? So that's that. Next one. Can we think about nasal angiofibromas? Yes. Can we think about another disease where there is abnormal formation of blood vessels, where the blood vessels, they form something like this? Does it look like a spider web? Yes or no? Yes. This is called telangiectasia. Telangiectasia, right? This is called telangiectasia, where we have multiple formations of telangiectasias and abnormal blood vessels in the body. This disease is known as hereditary hemorrhagic telangiectasia, or we call this as Osler-Weber-Rendu syndrome. Okay, is there a possibility that these patients, they can have abnormal connection between the arteries and the veins? Yes or no? They can have abnormal connection between the arteries and the veins. Something like this sort of an abnormal connection from the arteries to the veins. As a result, will there be increased venous return in these patients because all the blood from the arteries are going to the vein? The answer is yes, and this vein blood will go to the heart. So will the heart experience a high preload? Yes or no? The answer is yes. And over time, is there a possibility that the heart can fail in AVM, arteriovenous malformations? The answer is yes or no? The answer is yes. Are we clear, guys? Yes. So that's all about hereditary hemorrhagic telangiectasia. How important is this? This is very important. Okay. Next time, whenever you see telangiectasias in your question stem, I need you to think about two things. Number one, liver cirrhosis. Number two, hereditary hemorrhagic telangiectasia. Are we clear? Yes or no? Okay. There's another clinical scenario where you will see telangiectasia. That's after radiation to a mucous membrane. For example, in colon carcinoma, if the patient undergoes radiation, is there damage of the blood vessels? Yes or no? The answer is yes. In those cases, in chronic post-radiation problems, some patients will have telangiectasia in the colonic mucosa. So sometimes you can also have telangiectasias there. Are we clear, guys? Yes or no? Okay. So with that being said, we're done with cardiac pathology, except our discussion of ECG tracings. Okay. I had questions regarding UWorld about hereditary hemorrhagic. Okay, good. Can you do us a favor and unmute yourself and tell us the question so that we can also be aware? Dr. Hagar, if you wouldn't mind, please.
Yeah, he's an old man, I guess 60 something, 62 maybe.
Okay.
And he had this recurrent epistaxis, and he described the spider liver or the telangiectasia. He didn't try telangiectasia. He mentioned there is something in the skin look like, and from his description, I found out this is telangiectasia.
Okay. But were there these sort of spider web malformations?
Yeah, he is asking about the AV malformation in the STEM questions.
Oh, okay. All right, perfect. Okay, so that's that. So thank you so much, Dr. Hagar, for sharing that with us. So something to look forward to, okay? About a 60-year-old male in the UWorld where you will receive hereditary hemorrhagic telangiectasia-like questions. So please keep your eyes out for that question. So that's that. Okay. So right now, can we begin our discussion on EKG tracings? Or do you guys want another 5-minute break before we discuss EKG tracings? Can I get some feedbacks from the students? 5 minutes, okay. So let's take a break for 5 minutes. and then let's discuss EKG tracings and finish the lecture. Okay, so thank you so much. Let's take a break for 10 minutes, not 5 minutes. Okay, it's 1:01. Let's start the lecture at 1:11. Okay, I'm going to give you guys multiple breaks because today are we discussing a lot of information today? Yes or no? Fast answers, please. The answer is yes, right? So we need to make sure that we take proper amounts of break so that we do not get overwhelmed. And when you're taking a break, please refrain from staying in front of the computer or your books. Try to do something else. Go for a short walk, try to eat or drink something, and let's come back in 10 minutes. Okay, thank you so much. Okay, is everyone back from their break? Yes or no? Is everyone back from their break? Can you guys hear my voice? Okay, so we are almost done finishing cardiac pathology. And I just want some quick feedbacks from you guys. Did you guys understand cardiac pathology? Yes or no? Okay. Was the lecture, were they helpful? Did you guys understand? Yes? No. Very good. So next question. If you do not practice questions from cardiac pathology, will you forget cardiac pathology or not forget cardiac pathology? Which one? Very easy question. Forget. So what do we have to do? Do we have to do questions every day? Yes or no? Yes. Okay. How many questions should we do every day? Close to 20 to 40. Yesterday, you guys had a homework of doing 20 to 40 questions. Did you guys do the homework or not? All right. Okay. Website was down. Okay. Maybe I'm not sure. Website could be down. If it is, make sure that you do more today or tomorrow. Now, let's begin with ECG tracings. Now, in ECG tracings for step one, we only have to basically figure out what sort of a tracing this is and what really happens. Okay, first and foremost, let's talk about the number one, that is atrial fibrillation. In atrial fibrillation, do we have excessive impulse transmission from the SA node to the AV node? Yes or no? The answer is yes. As a result, do we have excessive atrial contraction or ventricular contraction? The answer is we have excessive atrial contraction, not ventricular contraction. Why? Does the AV node decrease the rate of the impulse transmission from the SA node to the AV node? The answer is yes or no? The answer is yes. As a result, we usually get atrial supraventricular arrhythmias, right? Arrhythmia, that is atrial fibrillation. So in atrial fibrillation, if there is excessive atrial contraction, will we see P waves, yes or no? Will we see P waves, yes or no? Okay, so number one is P waves. P waves will not be there. Okay, P waves will not be there. So number one finding of atrial fibrillation is no P waves. Okay. Another small piece of information. Okay, we know that the SA node is generating impulse and it goes to the AV node. And from the AV node, it goes to the rest of the conduction system, right? In atrial fibrillation, do you know what happens? What happens is there's another electrical foci. What is an electrical foci? Electrical foci is a group of tissues which has the tendency of generating electrical impulses. In atrial fibrillation, we have a group of, we have electrical foci that will arise from the pulmonary vein. Are we clear? From the pulmonary vein, or I mean from the pulmonary blood vessels. So if there are electrical foci in the pulmonary blood vessels, can they also contribute to the excessive electricity transmission to the SA node, to the AV node? Yes or no? The answer is yes. Okay, so that's another thing. So for atrial fibrillation, we will not find any P waves. Another thing is this interval, that is R interval. Is this the same length? Yes or no? The answer is no. So irregular R interval. Are we clear? Yes or no? Okay, how do we treat atrial fibrillation? Next one. Next concept that I want to talk about is if there's a patient who has atrial fibrillation, next concept I want to talk about. Let's say that the patient has atherosclerotic plaques in the atrium. Let's say that the patient has atherosclerotic plaques in the atrium. If there is excessive atrial fibrillation or excessive atrial contraction, right? If the atria is contracting, isn't there a possibility that one of these plaques can lodge off and enter into the systemic circulation? Yes or no? So the thing is, can atrial fibrillation give rise to embolisms? The answer is yes. Okay, the answer is yes. Are we clear? So for treatment purposes, should we prescribe an anticoagulation to the patient? Yes or no? Anticoagulant. Okay. Then after that, should we do rate and rhythm control? The answer is rate and rhythm control. Rate and rhythm control by how? By prescribing drugs that will prevent your excessive atrial conduction. That's that. Next one is, can we destroy the electrical foci? Yes or no? Catheter ablation of electric foci where? In the pulmonary blood vessels. Okay. Next one is, can we perform cardioversion if all of these fail? What is cardioversion? We can either give drugs to convert the excessive irregular contraction to normal contraction, or we can give electricity, which is called electrical cardioversion, if patients have a risk of developing ventricular arrhythmias. Okay, are we clear, yes or no? Next one is, if there is another patient who has this sort of a finding, that is, the patients have these sort of sawtooth appearance, sawtooth, right? Where the RR intervals, instead, over here, you cannot see the P waves either, but over here, the difference between atrial fibrillation and this one is that the RR intervals are the same. This is called atrial flutter. Are we clear? Yes or no? In atrial fibrillation, there was no P wave. RR intervals are not the same. Over here, there is also no P waves specifically, and the patients have a sawtooth appearance, and the patients have regular, normal RR intervals. Okay, next one. Next one is, if we see an EKG finding which looks like this, completely haphazard. What does this indicate? This indicates ventricular fibrillation. Will this patient have a tendency of going to sudden cardiac arrest? Yes or no? The answer is yes. Okay, that's that. If it's regular contraction like this, then what is the diagnosis? If it's regular, is this ventricular tachycardia? Okay. All right, next one is heart blocks or atrioventricular blocks. These are not vessel blocks. These are electrical impulse transmission blocks. How many types of heart blocks do we have? The answer is 3 types. Number 1, let's talk about the first degree AV block. What is first degree AV block? The first degree AV block is basically where we have an electrical transmission obstruction resulting in this sort of an EKG. The EKG looks something like this. Okay, over here. Okay, what's happening? Okay, over here, the P and R, this interval, this will be prolonged. So PR interval will be prolonged. How? It will be more than 200 milliseconds. Usually, it should not be this far away. It should be very close, something like this, right? But if we see something like this, PR is prolonged, then this is a first degree AV block. Another way is that although they are far apart, they will be same. All the PR will be same. Are we clear? Although they are far apart, all the PRs, they are going to be same. Okay, next one is how do we diagnose a second degree heart block? In a second degree heart block, we have two types. Yes, second degree heart block, we have two types. Number one is Mobitz type 1. Mobitz type 1 heart block. Mobitz type 1 heart block is basically this sort of a diagnosis where the PR interval, okay, where the PR interval will keep on increasing. This is the P, this is the R, PR. Do you see how the PR of this one is smaller than the PR of this one? This PR is longer. And this PR is smaller than this PR, yes or no? Can we say that the PR is progressively lengthening? Progressive lengthening of the PR. The PR distance will keep on increasing as we go this way. And then all of a sudden, there will be a, very good, there will be a beat drop. There will be a beat drop. Does anyone know what a beat drop is? Have you guys ever been to any clubs or any parties or any gatherings with friends where there was music or where there was DJ music in the back? Yes or no? Anyone? Very good. Okay, so I'm pretty sure you know what a beat drop is, right? It's something like, you know, like when the sound goes dishting, 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 and then all of a sudden they try to increase the intensity, and and then all of a sudden it just falls, and then the beat kind of falls, right? And then you have the main chorus, and then okay, so that's that sort of a sound. So this sort of a sound is basically how they try to increase the intensity of the sound, right? Giving you a feeling that the beat will drop, and then all of a sudden the beat drops, and then we have the chorus. We have the chorus of the sound. So this increase of intensity is how the PR keeps on increasing in length. Can we use this to remember that Mobitz type 1 is a beat drop, EKG? Are we clear? Just as how in clubs and parties, DJs, they do beat drops, we have beat drops in Mobitz type 1, where there will be progressive enlarging of the PR, and then suddenly the beat will drop. Okay, let's go for Mobitz type 2. What is Mobitz type 2? Now, in Mobitz type 2, what do we have? Mobitz type 2 is the same as Mobitz type 1 in beat drop. The same thing. There will be a drop beat drop. But do you remember in Mobitz type 1, the PR was increasing? Yes or no? Over here, the PRs will remain the same. So this is Mobitz type 2 is beat drop without PR prolongation. Are we clear? Yes or no? Okay, good. Now, next one is if there's an obstruction of electrical impulse transmission from the SA node to the AV node, and at one point, all the impulse from SA node are not reaching the AV node at all. So can the SA node contract by itself, and the AV node, is there a possibility that they will generate their own impulse? Yes or no? The answer is yes. So can we get an EKG where the atrias are contracting and the ventricles are contracting independently of one another? It's not linked, right? So can we get something like this, that over here, the findings are very easy to remember. That is the P and P intervals, the P to P intervals from this one to this one, they are the same. And the R to R intervals are going to be the same. But is there any connection between the P and the R? The answer is no. Okay, this is third degree AV block. Can anyone tell me one bacterial disease that we get in the woods that can cause this sort of a third degree AV block? They usually cause a target sign, very common in New York and eastern side of the US. This is very good, Borrelia burgdorferi, or we call it Lyme's disease. Okay, can we get third degree AV block in sarcoidosis? Yes or no? The answer is yes, because there could be, what happens in sarcoidosis, do we have granuloma formations? Yes or no? The answer is yes. Those granulomas can sometimes form in the electrical conduction system and they can cause third degree AV blocks. Okay, so that's that. From over here, what do we have to remember? Absolutely everything. So this is your another homework for today. Are we clear? Homework. I have discussed personally, I have discussed each and every line, and now your job is to read it and remember it and reproduce this information tomorrow in the class. Have I made myself clear? Yes or no? Perfect. Okay, so with that being said, can I congratulate everyone on finishing cardiac pathology? So congratulations. You guys have finished one of the, what can I say? One of the mountain topics of USMLE Step 1. Cardiac pathology, one of the most highest yield, and I'm so very proud of each and every one of you. Thank you so much for putting your attention in the lecture. Today, I'm going to end the class here. Tomorrow, I'll begin the class at 9:30. And since tomorrow we will finish pharmacology, we will start with questions in the morning. So please do not delay in joining the class. Please make sure you join the class as early as possible. Dr. Haidari, can you explain regarding AV nodal delay? Is it because of sodium current? The answer is AV nodal delay is because the AV nodes, they have a tendency of decreasing the rate and rhythm of the electrical conduction of the SA node. So if there is a AV node, if it detects a lot of electrical impulses from the AC node, it will inactivate the sodium channels and there will be less depolarization. As a result, there could be decreased transmission of impulses to the bundle of His and Purkinje. Next one is, if there is a block between SA node and AV node, then the SA node will generate the impulse by itself and the AV node will generate the impulse by itself. As a result, we have a hard block called the third degree hard block, where the P and P waves are going to be the same and the R and R waves are going to be the same, but they will have no connection with one another. Next, what are the diseases where we see third degree hard block? There are multiple diseases, out of which for USMLE, 2 of them should stand out. Number 1 is Lyme's disease caused by Borrelia burgdorferi, by a tick bite that we see in New York, Connecticut, Pennsylvania, and all the eastern sides of US. Next is an autoimmune granulomatous disease called sarcoidosis, where we see a third degree hard block. Okay. Can I unmute and ask? Yes, please unmute and ask.
Hello, Dr. Hedri. Thank you for the awesome lecture. I
You're
actually
welcome.
wanted to know regarding the AV nodal delay, which is usually a normal phenomena, but which phase of the action potential, actually, that is my question.
Oh.
Which phase of action potential is affected, or which phase which is responsible for creating this delay? That is what I'm not able to.
Okay, perfect question. And my apologies for not understanding your question. This is the phase. Okay. This is the sodium phase. This is the phase where they call the delay. So they close the sodium channels. So there's delayed depolarization. And as a result, they slow down the action potential.
Thank you so much. And
yes.
Also, I wanted to know that once we will be doing the pharmacology, will you be kind enough to correlate it with the SA and the SA node action potential or the myocyte action potential?
Of course, 100%. When we study, excuse me, my apologies. When we study antiarrhythmics, as you can see, I have to talk about the correlation of action potentials.
Thank
Okay,
you.
you are very welcome. Next one, Dr. Hagar, where can I find the previous lecture records? I have missing ones. Which lectures are you missing, Dr. Hagar? This is lecture number 7. Which lectures do you not have? Fast answers, please. Number 3 and 4. Okay, I'll give number 3 and 4 to you. Don't worry. Yeah. Okay, so if that's all for today, what is the schedule for this week? What do you mean, Dr. Fidel? Can you unmute yourself and ask me the question, please?
Yeah, about the holiday, because I remember you say the
the holidays. Yes, we have no class on Friday, on Christmas Eve, and Christmas is on Saturday, so it's a holiday by itself. And I'll try to make up the class on Friday later, sometimes in the future. Okay, so as to make sure that since we are trying to get 100 hours a month, we're going to make sure that there's absolutely nothing that will come in our way of getting that 100 hours, so that you guys are absolutely right for your money. That's the $1 per hour. So I want to make sure that it's exactly 100 hours. So this Friday, the class is dismissed, and we will take another extra class to make up for the lost class. Any other question by anyone else? Okay, good. Okay, so once again, be very proud of yourself. Be very proud of the knowledge that you have. Please try to make sure that you concentrate in your studies and solve questions. I personally believe each and every one of you have the potential to do really well. Not well, really well. I personally have a record. Let me tell you what my record is. My record is that all my students have USMLE Step 1 scores that are way better than my score. When I sat for my exam, I had a score which is an okay score, but my students have had the experience of scoring extremely high in the USMLE Step 1, and I'm really, really proud of that. And I see the same thing in you guys. All you have to do is focus on the lectures, contribute by solving UWorld questions, and make sure that you use us properly by asking us questions about UWorld. If there are any questions in UWorld which you do not understand, take a picture and upload it in the Facebook discussion group. In the Facebook discussion group. This is the Facebook discussion group. If you guys are not in the discussion group, then please join the discussion group. This is the Facebook discussion group. Join over here. I'm going to leave the link. And if you have any problems with any UWorld question, take a picture and post it in the group. Are we clear? Yes or no? Everyone? Okay, good. Perfect. Okay, so hope you guys have a great day. Thank you so much. And I'll see you guys tomorrow at 9:30 a.m. Okay, bye-bye now.